as a general pediatrician at the oldest hospital in the country and also the one with the best view, as you can see from the view out my window. So, as I said, this has been quite a difficult webinar to prepare for, knowing that we're talking to a very broad audience, from public sector doctors at various levels of care to private pediatricians. The range of causes and management of growth faltering is very varied. It can be as simple as an informal dietary advice given to a parent to a highly complex reason requiring skilled input of multiple experienced practitioners. So what my aim is tonight is that I'm hoping to provide you some sort of context to the problem. I'm going to approach it as a broad approach, incorporating revising what are normal nutritional requirements and infant feeding practices. I want to provide some back to basics assessment and management tips. And then I'm going to hand over to Lindo, who will take us through some illustrative cases and a more subspecialized approach. We obviously do have time constraints, so there's quite a lot that we can't cover. I'm not going to cover the basics of measurement and classification, no management of the sick inpatient, and we're not going to cover short stature. That's promised to come in a webinar next year. So to start, the definition of growth faltering seems simple: a slower rate of weight gain in childhood than is expected for age and sex, according to the WHO growth charts. But there are additional variations on this definition, including downward centile crossing. Some definitions have time specifications needing charting over 3 to 6 months, and some define it as the absolute percentile of a weight less than the Z-2. This unfortunately makes estimates of prevalence very difficult. Growth faltering usually refers to an infant or a preschool child and is generally identified on routine growth monitoring, like at vaccine visits or due to concerns expressed by parents or by health practitioners who review intercurrent problems and note growth faltering. Estimated incidence in developing countries varies between 10 and 20% of children presenting at a primary health care level, compared to about 5 to 10% in developed settings. It's reported that it's the reason for about 3% of visits to pediatric gastroenterologists and up to 5 to 15% to endocrinologists. Prevalence varying with age, more common in the under 12-month child and less, and ranged at about 2.2 to 5% in the preschool child. Prevalence in inpatients and children with underlying medical conditions will obviously be a lot higher. Just whilst we're talking about the topic, remember that actual weight loss, other than in the early period after birth, is unusual and usually flags the need for inpatient medical care. So I'm sure when some of you saw the title of the talk, you may wonder why we are now using the term growth faltering and no longer failure to thrive, the old terminology. This is for 2 reasons. So the word failure sounds rather disapproving and derogatory, with mothers or caregivers potentially feeling a sense of blame and responsibility when this negative implication of the word failure. The need to feed is intrinsic to most mothers, myself included, and there can be layers of guilt and blame when a child doesn't grow. The term thrive has now also taken on a different flavor. There's an acknowledgement that to thrive in a broader sense, a child not only needs nutrition, but also quality health care, a safe and nurturing environment, and learning opportunities, including early childhood development and schooling. This recognition has triggered multiple public health and government interventions, including the First 1,000 Days concept, nurturing care, and the Side-by-Side campaign. The recent South African Child Health Gauge further emphasizes this mind shift from just survival statistics to a child thriving in order to achieve those SDGs. Why have we devoted a whole webinar to this? Growth faltering impacts both individuals and communities. If not recognized and actively dealt with, it results in stunting and all the serious consequences listed here. It's not only in terms of health, but in terms of educational achievements, future earning potential, adult health of the individual, and impacts the next generation. So it's all of our responsibilities to recognize it and aggressively both prevent it and act on it timeously when identified to manage any reversible causes. So there's a lot out there, multiple guidelines, multiple policies available, many local ones aimed at primary healthcare level, like the IMCI and newly released Pack Child that most of us are familiar with. There's some guidelines looking at more broad global health public strategies and child nutrition towards preventing growth faltering. The evidence-based NICE guidelines, all 182 pages of them, are ones aimed to assist practitioners on advising parents and families and addressing growth faltering when identified. So with all of this available, where do we start? So, well, when I consider a child presenting on a ward round or in an OPD who isn't growing as is expected, I still run through this very broad approach that was taught to me by my GIT and nutrition mentor, who some of the older generation, including Mignon, will remember as Professor Joe Ireland. His lament in our GIT clinic was, why do all the children who don't grow always come to GIT? His comment is important to remember, as it's not always the gut to blame. His approach is fairly simple and tries to classify whether a child is not taking in sufficient calories to grow for a wide variety of reasons, as outlined here, or if the child may have a good intake but has losses of available nutrients or alternative utilization of energy that results in poor growth. It's important, of course, to remember that dependent on your setting, one can have both scenarios. Unfortunately, in South Africa, where sadly 29% of children live below the poverty line and 27% of children under 5 are stunted, suboptimal intake due to food insecurity or poor nutrition knowledge is still the commonest reason we see what the NICE guidelines term social environmental. However, intake at different ages requires different management, including the baby under a month, where focus is on optimizing breastfeeding. And our role as pediatricians is to tease out with other issues or overlapping issues. This group of children with poor intake, with underlying medical issues resulting in growth faltering, are often a lot more obvious. They can be picked up with a thorough examination, picking up things like your cleft palates, children with neurological issues, children with cardiac and respiratory disease. But growth issues are often multifactorial, and their management usually requires a multidisciplinary team. So this group is your classic FCP2 long case patients and your long stay pediatric ward patients, which we're not going to focus on today. One of the most challenging groups with poor intake, though, are those with behavioral eating disorders. And I'll expand a little bit on this after we review what is normal infant feeding. A group of children who come into the pediatric services at various specialties and levels of care includes those who have a good intake but aren't growing. And these require some careful consideration, a systematic approach. Remembering, although it's not always diet and TB, even though it often is, they are important things to consider and include. As I said, Lindo will elaborate on those in whom alarm bells should ring and for whom you do need a subspecialist GIT input for more extensive investigations. As emphasized, it's crucial to remember that inadequate intake will overlap with all other organic causes too and must be addressed. Okay, so as I said, what we're going to do is go back to basics, just reminding ourselves of normal nutritional requirements and feeding guidelines so that when you're assessing your patient, you can work out whether or not they are complying with this and whether or not this might be contributing to their presentation. We need to know what is normal to assess whether our patient is getting enough. So as you can see, children's energy requirements vary significantly depending on their age and whether they were born prematurely or at term. Both calorie and protein requirements decrease with time. Never forget, breast milk provides adequate calories and appropriate protein for the first 6 months of life. However, as is clearly seen on this graph, breast milk is an adequate source of energy up to 6 months, but the energy gap needing to be filled increases as the child ages, which clearly demonstrates why the timely and appropriate introduction of complementary feeds is crucial to meet the caloric and protein requirements, in addition to some milk, to maintain the expected growth trajectory. In the case of iron, breast milk provides a steady amount, with stores of iron being the main source during the first 6 months of life. But after 6 months, there's a large gap where stores are depleted that needs to be filled with iron-rich complementary feeding. This also shows why our preterm infants who don't have iron stores laid down in that last trimester need their 6 months of iron supplementation to prevent iron deficiency anemia, which is an independent factor contributing to growth faltering and ultimately stunting. By now, I know everyone in this audience, I'm sure, is very familiar with the first 1,000 days concept from birth to 24 months. So there essentially are 3 critical stages of childhood nutrition, 2 of which fall into this 1,000 days, breastfeeding and complementary feeding, whilst toddler feeding is the opportunity to maintain a healthy start. So I think I've convinced you by now the consequences of unrecognized faltering and stunting on human capital, but we must also remember the impact of good nutrition on actual child mortality. We're all very familiar with this data that shows how any breastfeeding significantly reduces all-cause and specific childhood mortality. However, the shift is now to an awareness that adequate complementary feeding can reduce under 5 mortality by a further 6%, and it's considered by the WHO as a hugely important non-vaccine public health intervention to reduce child deaths globally. There's unfortunately often multiple contributing factors in developing world settings, starting in utero, compounded by intestinal parasites, all in the setting of suboptimal complementary feeding introduction. But interestingly, regardless of socioeconomic setting, multiple large population surveys have shown consistently inadequate quantity and quality of complementary feeding in toddlers' diets. In developing world scenarios, there's usually low energy density food, with low protein and iron content, including bulking up with nutrient-poor fillers. But the Feeding Infant and Toddler study of over 3,000 under 4s in the USA recently also showed low consumption of iron-rich food, fruit and vegetables, a lack of variety, and that 67% of 2 to 9-year-olds generally only consume about 2/3 of their RDA for most vitamins and micronutrients. Consumption of sugar-sweetened beverages and 100% fruit juice are worryingly high in early childhood, which can lead to both growth faltering when toddlers are filled up with nutrient-poor drinks which take the place of food, or results in our parallel epidemic of obesity. So the guiding principles of complementary feeding are nicely set out in the European Society of Pediatric Gastroenterology, Hepatology and Nutrition Guidelines and Position Statements, which regularly is revised and reviews all available evidence. And they reinforce further the view of complementary feeding as a mosaic of elements that includes not only the food calorie and micronutrient content, but flavors and related behaviors that all need to function together for an appropriate intake. This includes recognizing the normal developmental stage called neophobia, which is an intrinsic resistance to new tastes and needs to be worked through during the introduction of solids. They nicely summarize current evidence on complementary feeding, which recommends that a wide variety of food introduction is key between the 6 and 12-month crucial window. This includes the traditionally allergenic foods that were previously avoided, and there's additional cautioning against additional salt and sugar in food to prevent developing a taste for these in the infant and toddler. There also needs to be lumpiness and texture introduced. There's also a global move towards what we call baby-led weaning or baby-led introductions to solids. This is a move away from caregivers feeding children with pureed food with spoons and babies getting a lot more granular with experiencing both tastes and textures. Quite a messy business for those there's parents of young children amongst us who have tried this. But what is emphasized is that it's important to allow the principles of establishing feeding cues, recognizing feeding cues on hunger and satiety to both avoid underfeeding as well as forced or overfeeding. Unfortunately, there's not a lot of high-level evidence presented on this, but it seems that the previous concerns related to choking are less significant than previously thought if all feeding is carefully observed and sensible. So what does Eske Began say about toddler feeding? Toddler feeding should be this continuum of your established good complementary feeding, but so much is dependent on family structure and attitudes. Screen-free family time is the ideal, as well as healthy in-between snacks, predictable meal times, which might sound like lofty aspirations and hard to achieve in small, chaotic households. So I'm sure all of this triggers you encountering some of those children in your practice, what I call the breast milk addicts who are constantly on the breast day and night, which tends to reduce their appetite when they never establish good intake. There's also the cow's milk or rooibos tea guzzlers who drink liters all day, often with associated profound iron deficiency and dental caries too. There's also the luxury addicts who fill up on sweet drinks, juices, and chips. And they all present with similar growth faltering at 12 months of age, which can be huge challenges to manage and break the cycle once tastes and behaviors have been established. There is so much readily available, valuable information in all of our Road to Health books and IMCI guidelines, as well as Pack Child, but constraints remain regarding the time limits of our primary healthcare workers in communicating this, as well as parental buy-in in households with unhealthy eating patterns in adults and older children, as well as our setting of food insecurity. The recently released PAC guidelines at primary care shows excellent summaries and advice to give for each age category. The bookshelves are also overflowing with books for parents. This might perhaps be an indication that it may be a bit harder than it sounds in the evidence-based guidelines. Okay, so I hope now we've established some reminders of what each age group of children needs in terms of calorie intake, food content, and context. So now we can re-look at our broad approach, which we're going to apply to each child. We're back to our mind map, looking at the child in front of us, whether inpatient or outpatient, who's been identified with growth faltering and sent to you. Children will access the health system at different levels of care, and this will dictate your interventions and actions. In our setting, the standard screening for growth faltering is done at routine vaccine, vitamin A and D worming visits. And when a child is identified at primary care showing growth faltering, there also needs to be an understanding of these factors I've described that may have contributed to the growth pattern so that appropriate advice can be given, intervention or onward referral to either NTP or a more specialized service. In some cases, the factors leading to growth faltering may be clear, like diet, like a child with TB, but in others it will not. And parents often fear that there's some underlying major illness and struggle to understand how their child has become undernourished. And we need to always remain sensitive to that. This flow chart is adapted from the Royal College of Pediatrics and Child Health, which shows the movement of a child through primary health care or GP level through to specialist with increasing investigations interventions. Just remembering the very young or sick child must be fast-tracked to specialist care. The same general approach can be applied wherever the child presents. And this is where I might be told that it's cheesy as it sounds. We really do need to always go back to basics with an extremely comprehensive history, with focus especially on the feeding history. Birth history is also important. As we already mentioned, preterm and low birth weight infants are at higher risk for growth failure and need more regular checks. In the premature baby, etiology is often multifactorial, from initial latching issues, increased demands of chronic lung disease, malabsorption in children with previous NEC. There's that high risk of iron deficiency as well as metabolic bone disease, and management must be individualized. Small for gestational age babies are another high-risk group. Taking a comprehensive family and social history is crucial to understand risks like maternal education, smoking, and other substance use, history of affected siblings, allergies, TB and HIV exposure. We also need to carefully interrogate systemic symptoms like significant losses from vomiting or loose stools, as well as a detailed developmental history to identify at-risk groups for poor intake. As I said, that dietary and feeding history is key, whether a short stay inpatient or in a private pediatric consulting room. We need the feeding history in detail to try and identify clues and issues to advise on and address, and the expertise of a dietitian is often needed at this stage to identify gaps. As I said before, breastfeeding babies under a month of age are considered a separate group in most guidelines, where inpatient observed feeding may be needed if weight loss is more than 10%, as well as to address any medical issues like hyponatremia, dehydration, possible bacterial infection, jaundice, as well as to support the mother to establish effective breastfeeding with monitored weight gain. A thorough examination, carrying on our traditional theme, includes careful classification of the anthropometry and classifying whether the child is stunted, as well as displaying growth faltering or wasting, noting the trend and identifying any suggestive pattern guiding your differential. Careful evaluation for dysmorphic features, clues to micronutrient deficiency, features of TB or immunosuppression are actively sought, and all systems thoroughly evaluated, including neurodevelopment. So after your thorough history and examination, your choice of investigations will become more apparent. We start simple and broadening, and Linda will elaborate more in her case studies on when it gets a lot more complicated. Be aware that investigations other than your routine dipsticks to exclude UTIs, your rapid HIV test, your HB, are actually quite unlikely to reveal a severe disorder if a child with faltering appears clinically well with no major systemic concerns. But obviously, whatever you find on examination is going to then dictate your next steps in terms of investigation, including referrals to other subspecialists like genetics opinion in dysmorphic children, perhaps booking a sweat test if you're worried about malabsorption. But if the dietary intake is good and doesn't explain the faltering, some simple biochemical tests, including a blood gas, a blood count with differential, may give additional clues to both etiology and complications. Some might wonder why a trial of feeding is considered under investigations, and this is controversial, but sometimes an admission for a trial of feeding is needed. The basic aim of which is to prove that with guaranteed and age-appropriate calorie intake, a child is capable of gaining weight. This is an inpatient admission in conjunction with a dietitian to advise on intake, and often a speech therapist to observe feeding after a failed nutritional intervention at primary care level, and where no obvious medical cause is identified. It may require nasogastric feeding while adequacy of oral feeding is being evaluated. What is reassuring is when there's good weight gain, it makes a malabsorption syndrome or metabolic syndrome less likely, and focus then needs to remain on intake. But we are most of us, I think, on the call are practitioners working with children where growth faltering is common from that socio-environmental setting, but one does need to remain extremely vigilant and recognize various patterns of presentation which require our further investigation or referral, especially those not responding to nutritional supplementation. An important genetic syndrome to consider is Russell-Silver syndrome. It can be suspected in a child with an initial initial low birth weight with preserved head circumference, as well as subsequent postnatal growth faltering, despite optimal intake and no obvious losses. Facial features are those of a triangular facies, and there's associated developmental delay. There's now genetic testing, but features can be heterogeneous and subtle, and management does generally require a whole team, including geneticists, endocrinologists who might at times consider growth hormone therapy. Fetal alcohol syndrome, although sadly so common, is actually often under-recognized, and many children are sent for failure to respond to NTP. Clues on birth history with low birth weight and microcephaly, and obviously a history of exposure needs to be sought, together with the classic clinical facial features and a growth chart showing that child crawling along a low centile regardless of intake. Once diagnosed, expectations regarding growth can then be adjusted. Those children will never grow despite NTP products. For mignon, something that can catch you out, and did catch me out once or twice in GIT when the children were sent to us for growth failure, is renal tubular acidosis, where the losses are often not obvious in the form of polyuria. I'm not going to go into detail, but I think most of you know that the renal tubular acidosis are the group of disorders with impaired renal acid-base regulation, with metabolic acidosis and subsequent growth failure. Important to consider, and why acid-base status is one of the screening level 2 investigations that I listed. Although children with primary immunodeficiencies may present with excess losses like chronic diarrhea and malabsorption, these conditions also need to be thought of bias, or when there's a combination of some of these clinical features listed in a child with growth faltering and no other obvious explanation, and the multiply done HIV test that is negative. So for me to wrap up, the final area that I'm just going to touch on that has significant complexity, and where in fact general pediatrics and GIT does overlap, is that of the spectrum of behavioral feeding issues, fussy eaters, and oral aversion. So feeding issues have various classifications, broadly divided into those with a poor appetite and those children with food selectivity, some of which we've already touched on. Those with poor appetite may need mental health professional input as well from infant specialists. There remains some controversy about whether this concept of neophobia that I mentioned in the ESPGHAN guidelines is a normal variant or an actual disorder, as it peaks to affect up to about 50% of 2 to 5-year-olds. As I said, it's the tendency to reject or be reluctant to try new or unfamiliar foods, and is thought to be traced back to evolution and protection from consuming potentially poisonous berries and other gathered food. But if not worked through and managed, it can affect food choices, shape taste preferences permanently, and significantly influence the quality of a child's diet, especially if good complementary feeding has not been established. This blends into the so-called picky eater and is demonstrated in the scenarios of the children I described with excessive or prolonged milk, tea, and juice intake, or limited variety or volume of solid food. They often reject the NTP products that are issued every month and are sent as failures of NTP. Children that are considered to have a very high food selectivity are those where their food repertoire is less than 15 food items. This tends to be more common in children with neurobehavioral issues like the children with autism spectrum disorder. Oral aversion is the most extreme form of behavioral feeding issues, with an infant or child often refusing to feed, choking, gagging, coughing, turning their head away when food is offered. There can be resistance to specifically swallowing lumpy food, spitting out chewed food, and subsequently growth faltering. It's more common in preterm infants as well as children with sensory issues like autism. It can also follow a painful or frightening experience, as importantly, as well as in prolonged untreated esophagitis, which can be from eosinophilic esophagitis or untreated reflux. And although these children make up a small group, they're important as they are very difficult to work up and manage. They need an invested multidisciplinary team. And this includes swallowing investigations and imaging. Key principles of management of this range of feeding disorders includes a patient understanding approach, positive reinforcement, gradual exposure to a variety of foods, family involvement, and consistency. Consequences of this untreated neophobia and picky eating is that the limited dietary variety results in exactly the stunting that we're trying to avoid, as well as micronutrient deficiencies, sometimes constipation, ending up in social anxiety. It's defined that the school-going child has an eating disorder when the child is unable to eat the family meal at the home of another child or engage with the normal family meal, and it interferes with normal social integration for age. A multidisciplinary team needs to establish a mealtime behavioral management plan involving our dietitian, OT, and speech therapist with creative feeding and a lot of sensory and messy play. Times input from child psychology and psychiatry is needed with cognitive behavioral therapy and anxiolytics. Sometimes the use of video observations of feeding practice to be used if there's any concerns about caregiver-child feeding engagement issues. The question often comes up, how long do we persist? When do we use home enteral tube feeding? And that generally is reserved and considered for severe growth faltering with the aim to discontinue this as soon as possible once the food aversion has been dealt with. It should be only initiated when there are serious concerns about weight gain, and if the assessment has been identified that it's needed after unsuccessful options as outpatients. It also often is thought that it helps take the pressure off the parent to try and get a certain amount and a volume in to achieve weight gain, reestablish a centile, but there need to be goals set to indicate when tube feeding is no longer needed. This is obviously in the child that doesn't have major underlying neurological disorders. Must be remembered that for all children, regardless of the cause identified, whether underlying major organic issues, whether an ex-prem reassessment and regular reweighing, usually monthly, and remeasuring, usually 3 monthly, needs to be done, especially in those receiving oral nutritional supplementation, to decide if it should be continued, but also to identify as those that aren't improving, to consider whether something is being missed from our broad overview. This may be the entry point where the specialist services come for an opinion. So we've reached the stage where my voice has run out, but also the point where I need to phone a friend, or you need to phone a friend and refer on to our tertiary services. So I'm going to hand over to Lindo, who will use some interesting cases and further insights into what to be done when help is needed from the GIT team and we have abnormal losses. Thank you.